It is now with great pleasure that I hand you over to our PRO, Mr. Anthony Goddard, who would also be chairing this night's event. Thank you.
Thank you so much, dear Francis. Good afternoon, ladies and gentlemen, and a special warm welcome to our colleagues from the Mona and Cave Hill campuses, as well as our special invited guests. I am Anthony Goddard, Public Relations Officer for the Pathology Club of UWI. I would like to thank you for joining us throughout this journey for the 9th and final installment of our Caribbean Pathology and Laboratory Medicine Student Initiative, CPALMSI. At this time, ladies and gentlemen, I am tasked yet pleasured to be introducing our featured speaker this afternoon, Dr. Greaves, Wesley Greaves. He will be sharing his wealth and experience and passion for molecular pathology and its application to the treatment of malignancy. Before we begin, I would like to give a brief background about Dr. Greaves and his lifetime achievements in the area of pathology. Dr. Wesley Greaves is the founder and CEO of NexGen Pathology Laboratory, established in 2013. NexGen is a fully serviced US medical lab, the US accredited medical lab that specializes in various pathological examinations located right here in Trinidad and Tobago. Dr. Greaves obtained his Doctor of Medicine degree from the Universidade Gama Filho in Rio de Janeiro, Brazil, in the year of 2002. He went further to complete his residency in Anatomical and Clinical Pathology at Bronx University and Rhode Island Hospital in Providence, Rhode Island, USA in the year of 2009, where he was a chief resident from April to June of 2009. Dr. Greaves completed his fellowship in hemopathology at the University of Texas MD Anderson Cancer Center located in Houston, Texas in the year 2011 and was a chief fellow from 2010 to 2011. He later completed his fellowship in the area of molecular genetic pathology in 2012 from the University of Texas. Dr. Greaves is also a member of various pathology organizations and societies. Without a doubt, Dr. Greaves stands humbly and proud as a pioneer in the field of molecular pathology. We are all honored, pleasured, and privileged for him to be here with us this afternoon. So, ladies and gentlemen, I welcome Dr. Wesley Greaves.
Thank you so much, Mr. Goddard, for that very flattering introduction. It's my great pleasure and honor to be with you guys today. It's very exciting. I'm very happy to be able to share a little bit of my knowledge and experience with you guys. Hopefully, some future pathologists and molecular genetic pathologists in our midst today. Before I get started, I would like to get a sense of of the audience, if you don't mind, maybe Mr. Goddard, or I don't know if you guys tend to do this in any way, but more or less, you know, who does the audience consist of today?
You mean in terms of their programs?
Well, so is everybody essentially a medical student?
Yes, essentially. I'm sure they could tell you in the chat as well, but more or less, we have medical students predominantly here.
From Trinidad, Barbados, and Jamaica campuses of UE, essentially?
Yes.
Okay. All right, perfect. So I have to apologize a little bit because I see your title for my presentation, which is not where I want to focus today. So having had a conversation with Dr. Catherine Morris, who would have told me about this opportunity, you know, I thought that it would be more beneficial to you guys to share a little bit about the training program of molecular genetic pathology, the opportunity, the career opportunity associated with this particular subspecialty, and what it entails. So essentially today I would be sharing with you more of an introduction to the subspecialty or the specialty of molecular genetic pathology, and perhaps at another time we could go into some more details, more technical and specific details on specific topics, like for example oncology or any other particular topic that we might be interested in. Okay, so I hope that I hope you're not too disappointed about that, but you know, as medical students, I'm sure you have a lot of theoretical classes on those topics. So I hope you enjoy the content today, which, as I said, is essentially just an introduction to the field. Hopefully, the presentation can be somewhat interactive as well. I'd love to hear from you, you know, questions, curiosities about the field, and maybe just general thoughts and comments as well. So let's get going. It's not meant to be a complex presentation. All right, so molecular genetics pathology or molecular genetic pathology, what is it? So it is a subspecialty of pathology, but it's also a subspecialty of clinical genetics, okay? And in this field, we use the principles, the theories, and the technologies of molecular biology and molecular genetics, which again, you should all be very familiar with at this stage of your training. The dogma of molecular biology and molecular genetics. And the range of diseases include Mendelian genetic disorders, again, which you're, I'm sure, pretty familiar with, disorders of human development, infectious diseases, and malignancies. So just, again, a general rundown of what the field entails. So just a broad classification of genetic disorders. These can be multifactorial, they can be single gene, they can be chromosomal, they can be mitochondrial, and they can be somatic. All right. So again, you guys should be pretty familiar with the dogma of DNA, RNA, and then proteins and whatnot, right? Genetic coding, etc., etc. These are some, it's a bit of a timeline in terms of some of the significant milestones over the years with regards to molecular genetics. So in 1997 was when the first sequencing, genetic sequencing methodology was identified. The name of that is Sanger sequencing. And as you get into this field, you would hear quite a lot about Sanger sequencing. It's essentially the gold standard for gene sequencing or genetic sequencing that we have. All right. So this whole sort of storyline of gene sequencing started in the 70s. Then we have the PCR technique, which was developed in the 80s. And again, so this one I'm sure everybody here would have heard about. So polymerase chain reaction technique, which is essentially a method to amplify genetic material, essentially RNA and or DNA. So whereas, so these are the two essentially basic principles that we use for analyzing genetic material. The first is amplification of the material, which is essentially via the PCR technique. And then we have sequencing of the genetic material so that we can identify the you know, what the sequence is and if there are any changes in the sequence and whatnot. So we have sequencing, we have amplification by the PCR methodology in the 80s. Then in the 90s, there was the seminal project called the Human Genome Project, and where we, for the first time, we were able to sequence the entire human genome. This was done using the methodology of Sanger sequencing. And amazingly, this took about 13 years to complete the sequencing of the human genome. By the time we get to today, we are able, with the technology that we have today, which is NexGen sequencing, to sequence an entire genome within a matter of hours, perhaps as fast as 24 to 48 hours, we're able to sequence an entire genome. So in the early 2000s, we had the publication of the first NGS method. So that's the methodology that I mentioned, very important for you to be familiar with. Again, so next generation sequencing, whereby we are able to sequence large time as opposed to years, which would be required with the traditional Sanger sequencing. We can sequence large amounts of DNA material, genetic material, very quickly via next generation sequencing. So this was in the early to mid 2000s or so. And I must say that I was very fortunate during my fellowship to be, so I was in one of the first groups that used this technology to develop testing platforms to use in the clinical setting. So we were one of the first groups to develop a panel of genes and mutations associated with hematologic malignancies. And so we took this technology, which was essentially in the research setting, and we translated that knowledge and that technology, and we were able to apply it in order to detect disease in actual patients. So then, so that's next-gen sequencing. So you see coming through the 2000s, again, we essentially, so we've had an explosion over this period of time now, where we're able to apply this technology to specific diseases, in particular cancer. I think cancer is really where it has made a massive difference. But of course, as I will share with you, there are other applications throughout the entire spectrum of medicine, where we use the technology of next-gen sequencing in order to detect and manage and even treat disease. So one of the main areas is infectious diseases. So again, the dogma for infectious diseases essentially over the years has been identifying these diseases via microscopy. So using special stains, for example, some of you may be familiar, for example, the Gram stain for bacteria, Gram negative, Gram positive bacteria. We typically classify microorganisms based on their appearances under the microscope. And in addition to that, then we could also culture these organisms, and grow them in cultures, and then do specific identification tests and whatnot in order to identify these organisms. Then we evolved to the methodology of immunology, where we're using immunologic methodologies in order to detect these organisms. So essentially using the paradigm of antibody-antigen specificity. And then this is the era now of molecular diagnostics, where again, we're able to use both the fundamental methodologies of amplifying these organisms' genetic material, as well as sequencing the material to identify microorganisms. And this is widely applied in medicine today. We're in the midst of a pandemic caused by the coronavirus. And as you all know, the gold standard of detection of that virus is via a molecular genetic test, essentially based on the PCR method. So this is widely applied both in, not only in virology, but in bacteriology and across the board, parasitology and whatnot, in terms of infectious diseases. Another area where molecular genetics pathology is widely applied is in disease screening. So from as early as the antenatal period of life, we are able to test cells of the fetus and do genetic sequencing to identify mutations or changes in the DNA sequence, mutations that are specific and predictive of potential diseases. So we can do that in an antenatal fashion. Then there's the application of cord blood banking as well, where we can store blood from the umbilical cord, which contains stem cells. And the idea is that later on in the life of that individual, if they, with genetic engineering, if there is need to produce a new tissue or a new organ, for example, we would have a source of stem cells whereby we could we are able to literally via genetic engineering to produce new tissues. And then again, in terms of hereditary diseases and whatnot, we're able from very early on to identify the likelihood of someone developing disease. So this, I just took this off of the internet. This is just one particular test that is commercially marketed, and it's pretty interesting. So it's saying here, every new patient wants a healthy future for their child, and to give them the best possible start. With newborn screening tests, your baby can be screened for a range of genetic conditions likely to develop within their first few months of life. And our Outlook newborn screening tests give you a clear picture of their predisposition to develop, for example, lactose intolerance, celiac disease, bitter tastes, medication-induced deafness, etc., etc. So, the application of molecular genetics is very wide, and it is likely to to perhaps, I would say, dominate the practice of medicine over the next 20 years or so. So it's a very exciting field, and it's one that I think that you should strongly consider getting into, because everything is going to be impacted by molecular genetics as you go into the practice of your profession. Another significant area is pharmacogenetics, which is essentially the application of the technologies and the fundamentals of molecular biology to determine the effects of drugs on certain individuals. Not only the effects of drugs, but we can develop drugs based on our knowledge of certain genetic predispositions associated with the metabolism of drugs, for example. Okay, so with regards to pharmacogenetics, there's several medical questions that we can pose and then apply the principles of pharmacogenetics to answer. So for example, the risk of developing certain diseases, kind of mentioned that before, screening of disease, diagnosis and prognosis of diseases, possible outcome of treatment with a drug, monitoring of diseases, chances of recurrence of disease. And then we can make therapeutic decisions. So recommending a particular drug based on the genetic profile of a patient. Sorry, determining the efficacy and safety of drugs, determining the correct dose of a drug, and personalizing the dosage of drugs based on, again, an individual's genetic profile. So, essentially the individualization and personalization of therapeutics. And then we have arguably, the most, or maybe, one of the most exciting areas where we apply molecular genetics, and that is in the field of cancer. And, of course, cancer has always been a challenge for us in the medical field in terms of not only diagnosing and monitoring the disease, but especially in terms of treating. And with the development of the technologies of not only sequencing, being able to sequence genetic material, but also to, as I mentioned, to amplify it and to be able to detect changes, mutations, and whatnot, it really changed our paradigm of cancer. We understood that cancer was a clonal disorder for the first time, which essentially means that it originated from one cell which replicated itself. That's a relatively new paradigm. Not only that, but we were able to classify certain types of cancer differently because we were able to detect genetic changes or genetic alterations that were specific to those diseases and distinguish it from others. So a very good example, a classic example that we use in this field is Hodgkin lymphomas. And previously Hodgkin lymphoma was a kind of a black box. We had T-cell lymphomas, we had B-cell lymphomas, and then we had Hodgkin lymphoma, this weird-looking thing. And I believe it was in the 90s where someone was able to identify that that Hodgkin lymphoma actually arose from a B-cell. So then we were able to classify it as a B-cell lymphoma, for example. And that's there's so many examples of that throughout the field of cancer, where we've been able to gain a tremendous amount of clarity on, across the spectrum, as I said, from not only diagnosis and detection of disease, but also helping us to manage cancer a lot better, and even to the extent of curing cancer. I'll show a couple slides demonstrating and exemplifying that as we go forward. You know, so the previous right. You know, so the whole concept of targeted cancer therapy, as opposed to the paradigm of surgery and chemotherapy or radiation therapy, you know, has changed the way that we manage cancer these days. So rather than simply applying drugs in a broad sense, what we can do is we can identify, we can molecularly or genetically profile tumors, and so we can identify specific prognostic genetic markers, specific predictive mutations in terms of drug sensitivity, drug resistance, and even in terms of adverse events, and then tailor our therapy. So you know, literally personalizing our management and therapy based on the genetic profile of cancers. The prototypical example of this is chronic myeloid leukemia, CML, which again, I'm sure you all have heard of and are aware of, the so-called Philadelphia chromosome, which is a translocation involving the BCR gene and the ABL gene. So we call it the BCR-ABL translocation involving chromosomes 9 and 20, translocation 922. This was the very first cancer where the genesis of the cancer, the cause of the cancer, was identified to be a genetic alteration. So this really introduced the era of genetics in cancer. So whereas initially, or before this time, and this was essentially in the 90s, we would use microscopy. So we look down the microscope and try to make a diagnosis of the disease. Once we discovered that there was a disease-defining molecular alteration, we were able to now use the methodology of molecular genetics to diagnose disease. And today, it is standard. You must identify the genetic mutation. It's not enough to just see the changes under the microscope. And the disease is actually now called chronic myeloid leukemia with translocation 922 or with BCR-ABL translocation. So we were able to identify a diagnostic genetic alteration. In addition, we were able to really characterize disease and realize that it involves a range of diseases actually, because, so I don't want to get too sophisticated here, but there are actually different ways that these two genes can combine when they're translocated. And so we have different transcripts that are associated with different manifestations of the disease. So which would involve either a more aggressive form or lesser aggressive form, for example. So that also gave us another level of sophistication and detail in terms of approaching this disease. And then not only was CML the first disease where we identified a genetic alteration that gave rise to the disease, but it was also the first one where we identified a specific therapy that targeted that abnormality. And again, I'm sure that you've heard of that drug. It's called imatinib. The most common commercial name is Gleevec. And that literally, so that was developed specifically to target the altered protein that is caused by this genetic abnormality. And so for the first time, we were able to treat a disease based on its genetic alteration. That's chronic myeloid leukemia, CML. And now that we knew the cause of the disease, we were able to develop a drug to target that protein. We essentially were able to bring certain patients, a certain subset of patients, to cure. So we were able to monitor the disease and also even achieve cure rates in those diseases based on shutting down that protein that was causing the abnormal proliferation of the cancer cells. So again, this is essentially, if, you know, we typically use CML as the model, as the disease model for molecular genetics in cancer. And these are the areas that we try to focus on. First, diagnosis of disease. Can we identify the specific mutations, specific genetic alterations that are responsible for causing the disease? Then we try to characterize those alterations. Typically, again, when you say cancer, even when you say CML, it's not one disease only. It's a range of diseases, and the more details we have about the spectrum of the disease, is the better we're able to manage it again, and to develop targeted and specific therapies. So it's diagnosis, characterization, and then developing specific targeted therapies for the disease based on the genetic alteration. So some examples are, that I'd like to share with you. And again, I'm sure that you guys have come across to one extent or another these diseases where we've been able, since CML, to characterize malignancies and then develop specific therapies, targeted therapies based on their genetic alterations. We typically divide these cancers into two big groups: hematologic malignancies and solid tumors. So we have, for example, CD20, which is a specific molecule found on B cells. So having identified that that is a molecule on B cells, we've been able to develop specific drugs that target that molecule, as opposed to broad-range chemotherapy that may destroy many other cells in the body. These molecules, they only target the B cells, and so it's a much more effective, and not only effective therapy, but also with a lot less side effects and whatnot. You have other molecules, CD33, CD52 in other hematologic malignancies, and here we have the BCR-ABL that I just spoke about in CML. And then a couple examples in solid tumors. We have HER2 new, which again, the prototypical cancer that you would be likely familiar with, where this targeted therapy is used, is in breast. Although we have now identified other tumors that have alterations, mutations in the HER2 molecule, and we are able to apply this dogma of diagnosis, management, and characterization of the disease, and then therapy. But breast is the prototype. And then we have other molecules as well that, again, I'm sure you've heard of: EGFR, VEGFR, VEGF, whatnot, etc., etc. So on a daily basis, we are discovering novel mutations in a wider and wider range of cancers that are specifically associated with genetic alterations. And well, one other aspect that I didn't mention, actually, that where we can apply the fact that we know that a malignancy is associated with a genetic alteration is where we can now, if we know that this is associated, so some of these are associated with hereditary syndromes, which means that the genetic alteration would be passed on from generation to generation and predispose someone to developing these cancers. We can now screen relatives of the index patient, and of course take preventative measures accordingly. So these are some diseases where in certain cases cancer is known to be hereditary. So we have breast, endometrium, prostate, etc., etc. I think, again, perhaps the most famous of them would be breast with the BRCA genes, BRCA1 and 2, BRCA1 and 2, where we're able to screen individuals and then take prophylactic measures, for example, prophylactic mastectomy in patients who we know will have a predisposition to developing breast cancer. So in terms of cancer and the treatment of cancer, again, you know, so it ranges from the sort of, I don't know if the word is primitive, but primitive may not be too bad of a term to use, which is essentially cutting it out, trying to cut it out, trying to cut out the tumor, and that is surgery. Of course, by the time you are able to detect the tumor, whereby you may want to apply surgery, it would be at a relatively advanced stage. So that's on one end of the spectrum, and on the other end of the spectrum, we're able to detect at the stem cell level. So some technologies that are being developed right now in terms of cancer screening is essentially taking a sample of your bone marrow, or taking a sample of your blood, and literally looking for circulating tumor cells even before the tumor is detected clinically and radiologically. Okay, and so we're able to, as I mentioned before, apply stem cell therapy and other targeted therapies based on the genetic profile of that particular cancer. So another slide just illustrating some of the cancers where targeted therapy is standard, is a standard approach today. Brain cancer, leukemia, skin, prostate, lung, liver, breast, and the list goes on actually. So that was a sort of a general overview of the field of molecular genetics and how it is impacting the broader field of medicine and some of the clinical applications, you know, that can be where we can use molecular genetics. And what I thought I'd also do, as I mentioned, is to give you a sense of how you can get into this field, what the training, what the requirements are, what the trajectory looks like, and a little bit about what the practice looks like on a day-to-day basis as well. Now, I must say that that this perspective is completely the United States perspective, the North American perspective. It's the one that I'm familiar with. This was my particular track. And so I am not sure how this works in other parts of the world, but I can certainly you know, tell you in very intimate detail how you can successfully pursue a career in molecular genetics pathology in the United States. So the first official training programs were only developed a relatively short while ago, about 20 years ago or so, is when molecular genetics was first officially recognized as a subspecialty, and it was recognized as a joint subspecialty between the American Board of Pathology and the American Board of Medical Genetics and Genomics. So even to date, this subspecialization is a joint subspecialization of these two boards. The training is a 1-year fellowship, so 12 months is the minimum amount of time in an accredited or recognized training program. You must have completed a medical degree, and you also would need to have completed a residency either in pathology or in medical genetics, and you must be board certified actually. So either in anatomic and or clinical pathology, which would be a 3 to 4 year residency, or a 3-year residency in medical genetics. And then you can go on to do the 1-year fellowship in molecular genetic pathology. So a little bit about the training program. During the program, the focus is on gaining a working knowledge of molecular procedures, molecular technology. Some of these include in situ hybridization, DNA sequencing, as I mentioned, so Sanger sequencing, massive parallel sequencing, that will be next generation sequencing. Pyrosequencing is another methodology we use. RNA-seq is another sequencing methodology for RNA, then DNA amplification, epigenetics, array technologies, etc. So it's a wide range of technologies. As a molecular genetics, during that 12-month period, you're usually exposed to all of these, usually rotate on the various benches, and you get the opportunity to have a very hands-on experience in these technologies. So by the time you finish, you understand in depth not only the technical aspect, but also the clinical application aspect of it. So you learn to analyze and interpret molecular data that's derived from performing these tests from clinical cases. You're also able to compose reports on based on those data, typically incorporating clinical, histologic, immunophenotypic, and molecular and cytogenetic findings. A big part of molecular genetics is also designing and carrying out experiments, as I mentioned. And I think molecular genetics, in terms of pathology, is probably the area that is most closely associated with basic research. So we tend to be, on that cusp of translational research. So connecting basic scientific research with clinical application. So there's a heavy focus on a deep understanding on the molecular basis of disease, and then translating these discoveries into improved testing and clinical applications. As I would have mentioned before, diagnosis, prognosis, and treatment of disease. So typically during a molecular genetic pathology fellowship, you would have done several research projects. So if you like to do research, if you like to work on the bench, this is definitely a field that I think you would enjoy a lot. And then of course there's the ethical, quality assurance and lab administration aspect of doing this testing, because we're not just doing it for research purposes on animals or stem cells and whatnot in a petri dish, but of course the goal is to apply the technology and the discoveries to medicine, which is caring for human beings. So there are significant ethical and quality assurance issues associated with that, and that usually comprises a heavy component of the training. So again, as mentioned, some of the clinical applications would include oncology, inherited diseases, infectious diseases, pharmacogenetics. And a typical day would include running experiments, so actual bench work. There's quite a bit of bench work. Also sitting in an office at the computer, analyzing the results, and then composing reports. And then reviewing those reports with attending molecular genetic pathologists for sign out. And then, as I mentioned, research projects. Typically, you do a couple of research projects in this training program, and then lectures and presentations, either attending or presenting yourself. And with this training, so this is an American board certified, as I mentioned, subspecialty. So at the end of that 1 year, there is a board certification exam. So you get to be recognized as an American board certified molecular genetic pathologist. And typically, people who do this fellowship program are recruited as directors of molecular pathology departments or as consultant molecular pathologists. It's a fast growing field, so the demand is pretty high. I've been in Trinidad for the last 7 years or so, 7 to 8 years, and I frequently get requests, actually, either through LinkedIn or I guess maybe, me being on some email list or something like that. I get people reaching out to me and inviting me to interview for jobs, in particular as a director of of a new molecular pathology department that they might be developing, for example. So it's a rapidly growing field with very good job prospects, I would say. In terms of training programs, so I just did a brief search actually earlier today for this presentation on training programs on one of the more common websites that we use in pathology. It's called Pathology Outlines, where they typically advertise for fellowship positions. And as you can see, there's a lot of openings, 6 immediate openings as of today. Unexpected openings, 22, and then they have openings going forward this year and going forward and whatnot. And then it's all over the country. So number of fellowships in this database, over 200. So lots of opportunities out there. And I think that's basically it. I hope you enjoy the presentation, and I would be happy to answer any questions. Actually, I look forward to some feedback from you guys. Any questions and comments are very much welcome. Thank you.
Thank you so much, Dr. Greaves, for your informative and intriguing presentation. So at this point, as Dr. Greaves said, we'll take any question based on Dr. Greaves' presentation. You can unmute your mic and ask your questions, or simply type your questions in the chat. Okay, so Dr. Greaves, we have some questions that we submitted before the session. The first question is, what inspired you or led you to choose pathology, and specifically molecular pathology?
So pathology, what inspired me actually was the fact that that it's a very challenging field. It's very broad, so it's not very limited and sort of narrow. Like, for example, if you're doing cardiology, you're just thinking about that field. If you're doing gastroenterology, you're only doing gastroenterology. But in pathology, you have to know a little bit about everything. So there's a lot of reading always, throughout your entire career, you have to keep reading a lot. Every single day you're in a textbook in order to practice, practice well. And every day there's something new, there's something intriguing. So it's a very, very stimulating field in that regard. The fact that it's extremely challenging from the perspective of trying to arrive at diagnoses, but also, trying to not only arrive at a diagnosis, but then the fact that you may be seeing something. For example, you do a bone marrow biopsy, and what may be occurring there may be something that has nothing to do with hematology. Maybe a disease that may be an endocrine disease or something like that. So you really need to know medicine in a very wide and broad way. So very, very challenging field, and it keeps me excited and stimulated every day. And then molecular genetics, I think that there's no way escaping molecular genetics for us as medical doctors over the next 20 years. You guys who are graduating the next couple of years or so, you will need to be very well familiar with the basic concepts of molecular biology and genetics. And so, as I mentioned, it's the area of medicine where I think there's the most amount of research, there's the most amount of new discoveries. That's where all the money is being invested essentially these days. It's in genetics, it's in molecular biology. And so you get to be part of new discoveries. During my year of fellowship, I can tell you, I was able to publish, quite a few papers of things that were novel discoveries and that kind of thing. So I also mentioned the fact that I was in the midst of an emerging technology, next generation sequencing, which has completely transformed the face of how we do oncology today. So, and that I think will be the reality for molecular genetics in the foreseeable future. So it's a very exciting field, and that's what attracted me to it in that regard.
Okay. Thank you, Dr. Greaves. So the next question that we have is, what is the link between individual genetic makeup and disease treatment?
Okay, that's a very, it's a kind of a generic question. I'm not sure exactly what the person is getting at, but the point is that each individual has a unique genetic code, right? Which we all know, and then each cancer, each disease. So it's I shouldn't say cancer as yet, because cancer is just one type of disease. But what we are discovering is that there's a genetic basis for most diseases. All right, and so that the point is that once we can identify the genetic basis of a disease, then we can not only predict the behavior of the disease, but we can also develop therapies to target those genetic abnormalities. So rather than trying to hit the tumor with radiation to try to kill the tumor cells, a way more sexy and sophisticated approach would be simply to develop a drug or molecule that goes into that particular tissue and switches off the mutation that is causing the overproduction of those cells. That's the case with CML, for example. So, in doing so, you essentially shut off the cancer and in that particular case. So that's that's one application. And then I spoke about pharmacogenetics as well, where certain individuals, we have mutations in certain enzymes that are responsible for metabolizing drugs. So so in certain cases, you might realize that even though a certain drug is generally prescribed for a particular disease, in one particular individual who has a mutation in an enzyme, that may make that individual resistant to that drug. And so it may not be wise to use that particular drug for that patient. So the applications are quite ranging. Those are a couple, I think, traditional examples of how we can apply individual genetic makeup to treatment of disease.
Okay, thank you. And lastly, do you have any advice for students aspiring to pursue pathology or molecular pathology?
Well, I absolutely do. Well, firstly, I would encourage you to seriously consider the field. I think it's a very rewarding, it's a very rewarding field of medicine, where you get to make a significant difference in patients' lives, even though you may not be dealing directly with the patients. And that was one of my main concerns, because I love clinical practice, talking to patients and whatnot. And when I fell in love with pathology, one of my concerns was that I was not going to be able to do that much more. But I think what compensates for that is the fact that that you are impacting the care of the patient in a significant way, making a big difference, diagnosing malignancy versus non-malignancy, for example, or the type of malignancy, the details of that malignancy, so that the doctors can tailor their management for the patient. So the first thing I would say is go into pathology if you're passionate about it. You gotta have a passion. You gotta have a love for it. And the second thing I would say is that you have to have a love for learning. In order to practice pathology well, you have to read a lot. You have to enjoy reading. You have to enjoy, going to the textbooks, and it's almost like it's kind of investigative work, doing investigative work. So you have to enjoy that aspect of doing medicine, trying to unlock very difficult scenarios, or trying to figure out very complex and complicated situations. I think that is what can be a lot of fun and very rewarding in pathology. And then I would say, if you like working in the lab as well, pathology would be the field that you'd want to get into. A lot of lab work, looking on the microscope, doing experiments, working on the bench in the lab and whatnot. So those are some things that I would say you'd want to consider.
Okay, thank you, Dr. Greaves. So we have someone is raising their hand. So Ms. Pacheco, you can go ahead and unmute your mic.
Hi, good evening. So I saw in one of your slides that you mentioned commercial genetic testing, and my mind ran on the fact that with everything you have extremes, right? And well, my question is it true that persons use molecular genetics on persons who are not even diseased? So I guess the non-ethical side of it, I was just wondering if that's true, that research is being done in that aspect. For example, changing the color of your eye or hair texture, things like that.
Right. So the thing about genetics, is that in the recent years, the technology has outpaced our ability to keep up with it in terms of legislation and ethical regulations and regulatory frameworks and stuff like that. So yeah, that's a big, it is a concern. It has always been a concern, actually. What are the boundaries that we should keep within in terms of doing genetic testing? You know, so that is always you know, a source of contention, a source of conversation in the conferences that we attend. There's always sessions on ethics and whatnot. And I think it's, yes, so to answer your question, you know, I can certainly tell you that from, you know, in terms of the basic sciences, to working on cells in petri dishes and then working on animals and whatnot, there's a lot of that stuff going on, cloning, and that kind of stuff. And I guess it's just something that as a society we have to grapple with and continue to try and keep on top of, because the technology is evolving very fast. And I guess as we go along, we'll have to figure out how to manage and how to regulate this field. But it is challenging because of the rapid rate of development of knowledge and technology in the area.
Okay, understood. Thank you.
Okay, at this point, if there's no further questions, we'll move on to our mentee feedback session.
Yes. Dr. Greaves, is this possible? You could stop sharing your screen, please.
Sure.
Thank you again for your educational and insightful presentation, Dr. Greaves. We received some excellent feedback based on the session, and some said it was informative, interesting, very interesting, eye-opening. You know, love the field, hate cancer, we all do. Thank you so much again. And as we draw to the end of the event, it's with great pleasure that I now present the vote of thanks for this evening's volunteer your time for this initiative to share your passion with us. Your words, advice, and knowledge will truly leave a permanent mark in our minds that we hope that the students in this virtual audience carry this information with them in their future careers. We would also like to extend our gratitude to Dr. Alfredo Walker and Dr. Catherine Morris, who was here earlier, our advisory board members, for joining us with your presence this evening. We appreciate your endless support and thank you for playing a key role in supporting us throughout our journey thus far. We would thank you all for taking your valuable time, efforts, and consideration in the investment to nurture and properly establish the future of pathology. It is not only an art of success, but one of greatness, showing us the paths that you have all walked. Additionally, I would like to say thanks to special invited guests who was present here tonight. It's a great honor to have you to join us tonight, this afternoon, and we hope to see you again in our future sessions. I'd also like to thank my two technical assistants, Amanda Francis and Gia Francis, for your help throughout this presentation and throughout this session. Last but not least, ladies and gentlemen, I would like to thank you all for joining us tonight for making our last event a success. We look forward to your continued support in the future. During these uncertain times, we extend wishes of health and safety to you and your family. And I would like to say good night and thank you.